case if some technically if we lose a connection or if something goes wrong, please call on my phone. And participants, I request you all to be patient. Within few seconds we'll be back because sometimes internet is not in our hands. So with that this one, Nana will start with the topic. Today's topic that has been given to me is on newborn resuscitation, complication and management. Okay. What we'll be doing is over next 45 minutes or so, we'll be talking about why newborn care is important, how we go about it, and we will decide about the objectives also. Just at a glance, see, a lustily crying and active newborn baby is a delight to all of them. A mother who has been waiting for 9 months, an obstetrician who has been taking care of the mother for 9 months, and also the pediatrician who is there to handle the baby, who is waiting to handle the baby. So it's all that we expect a baby to cry at the time of birth, right? Now, when as a doctor you stand there, what is our goal is ventilation of the baby's lung is the most important and effective action in newborn resuscitation. And in the entire next 45 minutes, we'll be just learning about what those different techniques are. What I'll be focusing on the next 45 minutes is, of course, I know I'm addressing undergraduate students. So I'll be just talking about, if at all, if a question arises to you on how do we write an answer, if at all, if you're asked to talk about newborn resuscitation, that is what I have restricted the content to. So I'm not going to a lot of technical aspects, but just to make the topic interesting here and there, we'll be talking a little bit about what is required to be learned about, right? So it's all about give a breathe and save a life. That's what it is. So in this particular session, we'll be learning a little bit about the changes in the physiology, then sequence of the steps that we follow during the resuscitation, and then we'll just in a glance look at what equipments we use, and then complications and management as a part of the topic. Okay. Now, why should me and you learn about resuscitation? Of course, I know it's an examination point that's required too, but most important is birth asphyxia, which accounts for about 19% of all neonatal deaths every year. So that's a big number. 5 million babies die because of birth asphyxia. And by appropriate resuscitation, if me and you learn how to resuscitate a newborn, outcome of thousands of the newborn babies will improve. And now that is where the need is, where me and you need to be skilled on newborn resuscitation. And 10% of all the babies require resuscitation and 1% need extensive resuscitation. What I mean to say is, if you just grossly look, 90% of the babies don't need anything to be done, right? Since we have institutional deliveries now more happening, so a few of the things that we need to take care about, and we'll be talking about that. But just to give a glimpse on why should someone learn is, just for those 10% of the baby who require some help and 1% of baby who require an extensive help in resuscitation. All right. Now, going further, what we have learned is every delivery is an emergency. And my teacher used to always tell me, unless a coconut is broken and unless a baby is born, you really do not know what is inside. So unless baby is delivered, we really don't know whether this baby requires a resuscitation or doesn't require a resuscitation. So, but when me and you prepare, it is like we prepare that every delivery is going to be received as an emergency, right? Now you all know how oxygenation happens before birth. It is the mother who is responsible. It is through the cord and the placenta that the baby will be receiving oxygenation, right? And fetal alveoli, which is filled with fluid, need to be replaced with the air. But unfortunately, in womb, the fetal alveoli is full of the fluids, and blood flow primarily is through ductus arteriosus, which we shall also look at pictorically a little bit. Just if you see in this picture, right, what you are seeing here right now. Okay, just a minute. Here in this picture, what you are seeing, okay, this is an alveoli. The dark black color that you see here is the constricted vessels, and the grayish thing inside that is the fluid. Now this is how generally the presentation is. There is fluid in the alveoli and vessels are constricted, and that's the reason why all the blood which is supposed to go inside the lung for oxygenation, it doesn't go. Rather, it has got ductus arteriosus through which it directly enters into systemic circulation. Now, this is where the normal blood, which is deoxygenated, is mixing with oxygenated blood in utero in the baby, right? Now, what should happen immediately after the birth is, once the baby is breathing, right? Eventually, whatever the fluid that is there in the what do you call? See, this is all the lung, so fluid filled lung. As the baby cries, some amount of the fluid is gone, and some more amount of fluid is gone, and ultimately you will find an alveoli which is free completely of fluid and is replaced by air. So what would happen is, this picture should actually turn to this picture. What is the difference between the picture? Now here, earlier there was a fluid, it is replaced by air, and here the vessels were earlier constricted, now they are open. So now what you will find is, the lung which is now open for, the lung is now open for receiving the blood. So now what would happen? All the blood start entering, arteriosus gets closed off, and normal functioning of the heart happens, right? Now, most of the babies, as I told you, 90% of the babies, this transition is automatic. We don't have to actually do anything at all. But there are some babies, those 10% of the babies who require some amount of resuscitation. Now, this word resuscitation basically takes us to a definition that talks about bringing from an apparently death-like situation to life. Okay. Now, we don't talk about this to 90% of the babies. It is only those 10% of the babies that need about it. But when we talk about resuscitation of a newborn baby, we just mean that we need to talk about these 5 steps, what we call it as ABC of resuscitation. Rather, we can expand for learning purpose, it is TABCD of resuscitation. T stands for temperature, A stands for airway, establishing an airway, B stands for breathing, C stands for circulation, and D stands for drug. Before we go deeper into the resuscitation, what we'll try to do in this particular session is just try to initially first learn what exactly this T, A, B, C, D basically mean to us. All right. Now, just let us start with the first term, that is the temperature. As we all know, temperature, T stands for temperature. Normally, a baby's temperature is 36.5 to 37.5 temperature. Now, this is called as thermoneutral range of temperature. At this temperature, baby does not bring out any of its metabolic activities or any of the mechanisms like a shivering mechanism that me and you experience on a normal cold weather. Whenever we feel cold, we usually either shiver or we rub ourselves. Now, all those mechanisms are triggered when you feel cold. But the baby would also feel the same thing if the temperature of the baby is not maintained between this particular temperature, 36.5 to 37.5, right? Now, this range is called as thermoneutral range because at this temperature, baby can maintain a normal extrauterine transition. Otherwise, if the temperature fall, we call it as hypothermia. But God does not send babies unequipped. So what he does is, he has sent the babies with an inbuilt mechanism called as a brown fat mechanism. This brown fat is located in the nape of the neck, in the axilla, and the interscapular region. What happens is, whenever the babies feel cold and when we are not attending the baby's need of the temperature, what basically happens is the temperature of the baby would go down. So to manage that, the brown fat, which is a readily disintegrable fat, start disintegrating faster, and then it produces warmth in the areas that I told you, where which the blood passes, carries the warm blood to the other areas, and the baby becomes warm. Okay, this is a mechanism that comes into play when we as a doctor don't play our role to maintain the temperature of the baby. Now, in a scenario where the baby is delivered, how are we going to manage the baby's temperature? This is something very important. And sometimes a question also comes in the mind that of all the procedure that is required, why are you talking about temperature in the beginning, right? Or this is the only thing that is needed to be done to the baby, because babies are already stimulated to breathe when they are in the womb. See, when the baby's temperature is not maintained, baby would, commence its shivering mechanism or other metabolic mechanism, wherein which it can consume the glucose, and you know that the only supply of the glucose to the baby until now is the mother's through the cord. But unfortunately now it is disconnected, and if you don't maintain that glucose, if you don't maintain the temperature, baby loses glucose needs, and the baby can go into hypoglycemia. And hypoglycemic baby, as you know, there are two things that are most importantly required for a baby. Number one thing that is required to the baby is the oxygen. Number two that is required is glucose. And in the absence of both, the first thing that suffers in a baby is its brain. And once brain damage happens, you know that it is an irreversible thing. That is the reason why temperature plays a major role, maintenance of temperature in receiving a newborn. So what we do is, you first take 2 sets of pre-warm cloths. Okay. Now, why 2 sets are required? Reason number one is, when the baby is born, what we first do is we receive the baby in a pre-warm cloth, right? The moment the baby is born, we receive it in a pre-warm cloth. How do you pre-warm it? We keep the cloth under the radiant warmer well before the delivery is happening, and we at the time when the head is being delivered, we immediately bring the cloth so that the baby is received in a pre-warm cloth. What happens is, when you measure the temperature in utero and extra utero, there is almost 5 degree Fahrenheit difference in the temperature. So at the temperature where me and you feel you feel hot, that is the temperature where the baby actually feels it is a normal temperature. So what you do is, you receive the baby in a pre-warm cloth, then you start drying the baby. See, once you dry the baby, what you will find is the cloth that was earlier used becomes wet, right? Now, what you do is, in the second step of the maintenance of temperature, you remove that wet linen, right? We don't keep that linen continuous, because what would happen is, baby would again further start losing weight, temperature, if that temperature, the wet cloth is not removed. So what you do is, so first receive the baby in a pre-warm cloth, wipe the baby, and then put the baby in a second warm cloth, okay, second cloth. So what we did initially, so when you talk about maintenance of temperature, baby is received in a pre-warm cloth, you wipe the baby, remove the cloth, and wrap the baby in a second cloth. So this is the step that we do. Now, once you know that you have wrapped the baby, baby is stable, you have cut the cord across. If the baby is fine, we usually keep the baby in between the breasts of the mother, and you continue maintaining temperature there. But in certain babies where we can't continue maintaining the temperature of the baby, what you do is, you take them to the room where there is a radiant heat warmer, right? You start nursing the baby under the radiant warmer to maintain the further temperature. Okay, so I hope I have cleared you what we mean by temperature. So as you know, we are now learning about TABCD of resuscitation. Of them, temperature starts as a first thing, and for maintenance of temperature, you need 2 pre-warm cloths. In the first cloth, you receive the baby, you wipe the baby, it is wet, you remove that cloth, receive the baby in a second cloth, and if the mother and baby both are stable, you continue nursing the baby between the breast of the mother. And if at all, if the baby need to be separated from there, you cut the cord and you take the baby to the radiant warmer and you start nursing there. Right? This is what is called as a warm chain. Right? This is how you take the baby from a point of warmth to the point of the warmth. Right? So this is the one. Now, second term that we have in TABCD of resuscitation is establishing an airway. Now, what do we mean by establishing an airway is, we really don't establish an airway. It is like the airway, already the God-given airway is there. What we are trying to do is, you try to make the air passage free from obstruction for air entry. Now, this is what we call it as in establishing an airway. Am I audible and clear? Am I audible and clear?
Yes, sir. Yes, sir. You are audible.
All right. So this is how we, this is how the establishing airway basically tell us. Right now, what you do is, the most important thing that has to be understood is, when you're talking about obstruction, from where does this obstruction come to a newborn baby? Now, usually you find the blockages in the air passages are either from the secretions that are happening from mucous membrane, either in the oral cavity or in the throat. Second one is, the position of the baby may not be correct, that it might be occluding the pathway. and the last one, that is, there can be some meconium plugs, that might be there in the baby who is meconium stained, that can be causing an obstruction. There are furthermore, but most common are these three, right? Now, so what we do is, let us take the scenarios one by one. The first and the foremost important thing that you do to manage an airway is you position a baby. Now this position is called as sniffing position. Just watch this baby carefully, that is being shown in the picture. Here, you know that the baby is lying down flat in a supine position, and then a shoulder roll is placed under the shoulder of the baby such that you raise the shoulder by 3/4 of an inch. Right? What you do is you put the baby in a supine position and you already have a shoulder roll, and this shoulder roll is placed under the shoulder of the baby so that you can raise the shoulder by 3/4 of an inch. What would happen in this position is, just look at this, what would happen in this position is, there are three possibilities if the position is not maintained. The first possibility is that the baby's neck is flexed, and you can see here what would happen. The airway should have been actually like this, but because of this position, the air entry becomes difficult. Look at this position, the baby may be hyperextended, and because of the hyperextension, what would happen is the air entry may not be ideal. Okay. Now, second thing that can happen is, look at this picture, right? Now, this is called as a normal airway. You can see here from the oral cavity, from the nose, the airway is directly connected so that the baby can breathe easily. Now, our goal of positioning is to bring the baby's airway in a straight line so that the air entry can happen easily. Now, this is achieved how? This is achieved by keeping a shoulder roll. This is achieved by keeping a shoulder roll under the shoulder of the baby, which we have to prepare well in advance before the baby is handled. Okay. Now you can see here there are two incorrect postures. Number one is a hyperflexion. Okay. Hyperflexion. This is incorrect. And flexion. This is hyperextension, where the baby's neck is quite extended more. Right, more than expected. You can see here it is so much extended. You can see here it is quite flexed, and this is the normal one. This is how you achieve. This is what is expected in the positioning, when you mean the positioning. All right. Now let's look into the second way of clearing airway. Second way of establishing airway is where you suction out the contents that are there in the nose and the throat. Okay, these are the two areas. When the baby is there in the womb, as you know, its entire lungs are fluid filled, and when the lungs are fluid filled, the only way of their exit is it has to either send it out through the mouth and send it out through the nose. So in this process, there are chances that there are some more accumulations here. So what you do is, the larger cavity is the mouth, smaller cavity is the nose, and the dominant area of air entry is the mouth. So what you do is, M first, N next. Right? That is how the alphabetically order is, right? M comes first and N comes next. So you have to remember it in this way, that you have to suction the mouth first and suction the nose next. You can see here the baby is turned to one side, and whatever the superficial secretions are there are taken out, suctioned here, and then you suction the nose so that whatever the secretions that were blocking, they get cleared off. Right? Now the third way of establishing an airway is an artificial way. Okay. Now what you do is, since it is not being cleared either by positioning or it is not being cleared by the suctioning, so third role is used only when the baby is not what you call responding in a way. What is done is, you take a endotracheal tube, insert it through the mouth, and then pass it into the trachea. Now this is the last way of making, you see, this might look simple the way I am saying it, but now this requires a lot of technique and practice. But just to know that this also is a component of establishing an airway. All right. Now some babies might have few problems, like the baby can be having a meconium baby, right? Now what would happen is, it cannot just come out with a simple suctioning. So what you do is, you insert a laryngoscope and examine the throat and do a proper suctioning of the throat under the proper visualization of the baby. right? So now we looked for three things when we talked about establishing an airway, right? Number one was to position the baby. Number two was to suction the baby, and number three is keeping the endotracheal tube in the baby, right? So these are the three ways of establishing breathing. All right. Am I clear? Is it going on fine? Am I audible?
Yes, sir. Yes, sir.
Yes,
Great.
sir.
All right. Now we looked of the TABCD. We looked about temperature. We also now looked about how to establish airway. The next component of resuscitation is where you establish breathing. Okay. Now B stands for breathing. Now establishing breathing has got two components into it. When you want to establish breathing, you can either give a tactile stimulation or you can give a bag and mask ventilation. Okay. Now these are the two components that come under the heading of breathing. Now tactile stimulation, when we mean, what we do is we adopt two different methods that are usually practiced, right? Now the first method that is practiced is where you tap the sole of the baby. You tap the sole of the baby. And what you do is, this is the most commonly practiced method, where you flick on the sole of the baby and you also count 1, 2, 3. Don't go on tapping the baby. It's like somebody who is not breathing in, you go and tap them or you shake them, and the sudden respiration stimuli comes in, and then we start breathing. Now similar is the mechanism that is used. Now what you do is you give a tactile stimulation here and the baby starts breathing. Then another third way of giving tactile stimulation is where you can pass your hands under the baby and then you can give a gentle massage on the spine of the baby. Then what you will find is the baby start breathing. All right. Now these are simple methods that are used, very successfully used for stimulating the respiration of the baby. Then another mechanism which is used for bringing in respiration for the babies who are not breathing by themselves is where we use this unit called as ambu bag. Now you can see on the ambu bag there is a mask, there is a bag. What you do is we keep this mask on the face and nose of the baby, and then you artificially, mechanically, you press this bag so that the air enters into the baby's lungs and the baby gets ventilated. Okay. Now, since the baby is not breathing on itself, we are giving a mechanical force to make the baby breathe. So this is the mechanism. I'm just trying to make it simple here. There are steps involved into this, but as of now, let's understand what we mean by bag and mask ventilation. Right? I hope we are clear about the three terms. Initially, we talked about temperature, and in the temperature, we looked in where the baby was received in a pre-warm cloth. We removed the wet cloth after wiping. Then the baby was took back into the one more new fresh warm cloth. And if the baby is fine, we continued nurturing the baby between the breasts of the mother. Otherwise, the baby was moved to the radiant warmer. Most of the babies settle with only this process. If at all, if further procedures are needed, then we try to establish airway by doing again three things. Number one is that we try to suction out, we try to position the baby, and third thing is that we intubate the baby. In the third heading, we saw about establishing breathing, and under the breathing, we looked about two components. Number one was tactile stimulation, and the second procedure was bag and mask ventilation. Okay. Let's move further to circulation. Now, circulation, what we mean is, all of us are aware about cardiopulmonary resuscitation. Now, as you know, the baby who doesn't breathe for over some time, now eventually the oxygen level goes down and the body starts losing its energy in compensating the needs of the baby, and so also does the heart do. What happens is, when the heart rate start going lesser than 60, now we need to take care about the circulation by our own. Now the mechanism is very simple. If you can just look at this, this is the heart. It's located between the sternum above and the spine below. And what you do is we squeeze the heart with our thumbs and our hand in such a way that you squeeze the blood out of it. Okay, no, it is done technically, of course. It's that we have to learn how exactly that has to be done. But just to define your term circulation, I'm just trying to tell you in a layman's language. But this is how it has to be understood. That there is a heart here, we squeeze the heart externally so that whatever the blood which is not pumping out, baby can take it up and immediately the heart will start restore its normal function. when enough blood is pumped out along with the ventilation. This procedure is not done singly. Whenever we want to improve circulation, there are two deficits that the baby is having. Number one, heart is not functioning because of the prolonged hypoxia, and then the baby is already having hypoxia. So you need to take care about giving oxygen by bag and mask or by endotracheal intubation, and then simultaneously also along with that do the chest compressions. This is how it is usually done. Usually two techniques are used. You can see here an adult case, if patient is there, we keep both our palms and then we squeeze. But here we do not use the pressure by using the entire hand. You can see here we use only two fingers and the rest of the hand is surrounding the baby. Same here, one hand is under the head of the baby, under the back of the baby, and we use two fingers over the chest of the baby and we compress, right? So this is how you bring about circulation. Okay, now I hope I'm clear about what we mean by circulation and when we use it. Then the last thing, we need to, as an Ayurvedic doctor, we don't have to learn about the drugs, but I will tell you one good news, right? The good news is the current guidelines for resuscitation that says is you are not supposed to keep any medications that are required for resuscitation in your NICU, because these things are mostly not required and are very dangerous to be used if not used technically and appropriately. But just since there is a point that has come about on drugs and medication, I'll just brief you about when are we going to use drug. See, you started giving initially the administration of chest compression you administered, then positive pressure you you gave with 100% oxygen, and then heart rate was below 60 and you tried to give it the chest compressions, but even then the baby did not respond to you. Heart rate is constantly going below 60, the baby is not breathing, and it is at this point that you have to think of medicating the baby. And few of the medicines that are used are for increasing the heart rate, epinephrine is used. Okay, and this is the only medicine which is of a great importance. Then other soda bicarbonate cannot be used without establishing of breathing. But just for your understanding purpose, we got to understand that these are the kind of medications that are used. All right. Now we learned about 5 techniques, right? We learned about T, A, B, C, and D. Now, in the further, when we are going, when I mean temperature, you must understand what exactly do we mean. When I say position, you should know that I am talking about a sniffing position. Whenever I talk about positive pressure ventilation, you should know that I am initially talking about the bag and mask ventilation, or it can be an optional with endotracheal intubation, which is connected to bag and mask ventilation. So let us, with the understanding that you have understood all the 5 terms, that is temperature, airway, breathing, and circulation, and the drugs. Drugs, we are not going to talk about it any further, but these are the way, right? Now, when you start breathing, right, what I mean to say is when the baby comes in, if at all, if we are there in the labor room, some of us might feel, all these procedures might need. Excuse me, am I audible? Is everything going on fine? Clear?
Yes, sir. Yes, sir.
All right. Now here we have to understand that we do not have the one important scarcity that is there in the labor room is the time scarcity, right? Now we call it as the first golden minute, right? We do not have time that goes beyond 1 minute, right? Now if at all, if you are establishing airway, you have only 30 seconds. Next, to take up further breathing, you have another 30 seconds. If at all the circulation has gone down, heart rate is going down, another 30 seconds to revive the baby. And the goal is at least within next 2 minutes, baby has to be brought to the normal situation. Now, any baby who takes a time beyond this usually suffers one or the other component of asphyxia, one or the other outcome of hypoxia, and these babies, it's so difficult to manage these babies throughout the life. So when we are there, we got to understand that we have only 2 minutes to completely bring the baby out of the situation, because whatever the cord blood that is there running in the baby can sustain itself only for 2 minutes without any help. But beyond this, the baby cannot really sustain with the amount of oxygen that the baby is having. Okay. Now, once we know the terminology, Let us understand one more component, that is the Apgar scoring system and resuscitation. How are they related? I'm not going to deal completely about the Apgar score. You know that the 5 components are there: heart rate, respiratory rate, muscle tone, and then the grimace and the color. So these are the 5 components that are there in the Apgar scoring system. But please understand, resuscitation is initiated before the scoring is assigned. Me and you are not going to sit and keep on scoring and then you lose that golden minute. Please understand this, right? So what you are got to supposed to do is, when you are there in the labor room, this Apgar scoring system has got its own value, because it in general expression is about the respiratory system, about the cardiovascular system, about the central nervous system, the entire 3 core system it gives an idea about. But we're not going to wait for the score to come for resuscitation to start. So you've got to evaluate the baby and start giving the necessary resuscitation steps. Okay, so moving further, please understand that now let us assume that you, with the enough information that is required, you have been called in the resuscitation room. What are all the things that I am supposed to prepare? Number one is, you need to anticipate the need for resuscitation. Right now, a baby may be preterm, or there might have been a prolonged labor, or there can be a obstructed labor. You need to understand that which baby might require an extensive resuscitation. So you prepare accordingly. Your preparation is 2 ways. Number one is, you need to have enough equipments. Then you need to have enough personnel, that there has to be one helper and you and other nursing staff who are going to help you. Now, you might anticipate anything and everything, but sometimes birth asphyxia can come as a surprise. You really don't know, right? And then you need to divide, take a proper history. That is the reason why we spend some time, at least some time before the delivery happens, with the mother, so that you can rule out, are there any antipactum factors or intrapartum factor that can bring a problem in the normal breathing of the baby, right? Now, when you talk about being prepared about the personnel, you need at least 2 trained personnel. If one fails, the other one is there as a backup. And then you need to have few equipments, like one is, you need to have a radiant warmer, which is heated and ready to use. You're not going to on it when the baby is delivered. Okay. And then all resuscitation equipments, all of them should be immediately available and working order. This is the most important. Sometimes you need laryngoscope and you do not have a cell into it. That is a dangerous situation. So all the equipments that are required should be available and they should be in a working order, right? Now you have to also understand that there are possibility that there can be a twin delivery. So you should have 2 teams working, right? So multiple births, multiple teams are required. Usually what are all the equipments that are required is, number one, a mannequin is required so that you can practice well in advance. A radiant warmer is required, gloves are required, and bulb or suction catheters are required for suctioning. Stethoscope is required to evaluate the baby. Shoulder roll should be ready to position the baby. A towel is required to wrap the baby. Your umbo bags should be there, you know. And then the flow meter is required to monitor the oxygen flow. Masks are required of the appropriate size. And then you need to have a proper way of administering oxygen. Laryngoscope and blade is required. Suction catheters are required. Endotracheal tubes are required. And then meconium aspirator, nowadays nobody uses it, so you can stop it off. Clocks, earlier we needed this, but today we have our mobile phones that can use as a clock. Okay. And then mechanical suctioning and tubing, these are all the most important things that are required when you are going to receive a baby. Now let us see what exactly are we going to do when we receive a baby. What I am showing right now is a little bit older version of newborn resuscitation. But this resuscitation flowchart will actually give us an idea about how we go about resuscitation at the time. Okay. Now, the new thing that I'm going to tell you orally, but let me just tell you about the old version and then I'll correct you on the newer method of resuscitation. See, there are 4 questions that you asked before and at the time of delivery. Number 1 question is whether this baby is term gestation, because a preterm baby will bring us some problem. Whether it is meconium stained baby, because a meconium stained baby can have its own problem. Whether the baby is breathing or not, because a baby who is breathing needs very minimum care and not breathing requires a lot of care. And then whether the baby is having good muscle tone or not. Okay. Now, The only change that we ask here is whether the baby is breathing or not. We don't ask so many extensive questions, but they are good questions to be asked at the time of delivery. Now let's assume I asked 4 questions: whether the baby is having term gestation, it's clear of meconium, baby is breathing or crying, or the baby is having good muscle tone. If all the 4 questions answered are yes, okay, such baby will receive a routine care. You don't have to do anything. God has already sent this baby with a proper transition. What you do here is you just provide the warm. Now you know how to provide the warm. You clear the airway only if needed, otherwise you don't do it. Then you dry the baby and then you assess the color of the baby. Now these are the only things that you do, and the good news is 90% of the babies require only so much. You don't have to do anything much than this, better than this. Now let us assume for any reason, if any one of the question answered is no, that is the baby is not breathing. Okay, that is the only question that you asked today. Let's assume the baby is not breathing. So what you do here is, again you provide warm, because that is T stands first. Then what you do is you position the baby. Now you know what positioning is. After you position the baby, you will clear the airway. You do by doing a suctioning as per requirement. Then you dry the baby. Then you stimulate. Now you know how stimulation is given. And by the time you are done all this, the baby has lost position, so you reposition the baby. Okay. So what is done? You provide warmth, you position the baby, you clear the airway, you dry, stimulate, and reposition. By the time you are done this, most of the babies will have a good response. What you do is you have to evaluate respiration, heart rate, and color. And the good part is, if the baby is breathing well after doing this, if the baby's heart rate is fine, and if the baby is looking pink, now this baby requires an observational care. Please understand, we need to tell the mother, go ahead and tell the mother, saying that this baby, when it was born, it did not cry, so but the baby is now stable, but I'll be coming here every 15 to 20 minutes once to see the baby if the baby is doing fine. Right, so baby requires a proper observational care, right? And then if the baby is breathing, everything is fine, if the baby is cyanotic, what we need is, we need to give a supplementary oxygen to this baby, right? Now once, if the baby becomes pink after giving oxygen, the baby will again further go for observational care, right? Now let's assume that the baby still persists with apnea, baby is not breathing, and if the heart rate is still less than 100, it is at this point that we choose to do positive pressure ventilation. So at this point, you also know what we mean by providing positive pressure ventilation, right? Now you know that we need to give either bag and mask ventilation or endotracheal intubation. Fine. Now we further, what you do is, after giving positive pressure ventilation, if the baby's heart rate improves, color improves, tone improves, then this baby will no further go to the baby mother. This baby will go for post resuscitation care. We need to monitor this baby, because this baby had a severe problem at the time of birth. Fine. Now after this, if the heart rate is still down, then we go to the next step. What is the next step? We continue giving positive pressure ventilation because the baby further needs oxygenation, but we add chest compression. Now you know what we mean by chest compression. Now after doing this, if the heart rate improves, you continue positive pressure ventilation until the heart rate becomes normal and the color becomes pink, but the baby will further go into resuscitation care. In spite of doing these procedure, if the baby still further, if the baby's heart rate goes down, now it is at this point that to the positive pressure ventilation and chest compression, we add medications, as I told you, which is usually now not practiced, but this is the entire chart of giving resuscitation to the baby step by step. Okay, and to do this entire step, the only time limit that you have is 1.5 minutes to 2 minutes, before which you have to complete the entire story of the baby and you have to bring the baby to the normalcy. Right? So this is how you attend to the baby who is born at the time of birth. Actually, I wish I would repeat this, but because of the time constraint, I'm not going to repeat this. Right? You can always watch this again. Yeah. Now this is what we call it as TABCD of resuscitation. Okay. Now talking about few hazards and harmful things in the olden periods. Okay. Now of course nobody does. Am I audible? Am I clear?
Yes, sir.
Yes, sir.
Right. Yeah. Right. Now here, There are few harmful things that are done at the time of deliveries which are not supposed to be done. Number one, there were older practices there, but unfortunately still there are few areas where these things are done. Slapping the back of the baby, because most of the Bollywood movies, they show it when the baby is delivered, they slap the back, but this can cause bruising to the baby. And some of them, they squeeze the rib cage thinking that all the fluid, let's bring it out, we'll end up in fracturing or bringing pneumothorax in the baby. Some of them, they force the thighs on the abdomen thinking this is the way of taking the fluid out of the lung, but we'll end up in liver or a splenic rupture. Some of them think, Muladhara chakra is there at the anus, so let's dilate this anal sphincter, but this can tear the anal sphincter if done in a wrong way. And hot or cold compresses are given. And unfortunately, we have seen in our practice many of them in being practiced. So a hot or cold compress can give a hypothermia, which can be very dangerous. And the last and the most dangerous thing is shaking the baby. Some of them, they hold the leg of the baby and they shake, and because the blood rushes down in a rapid way, this can cause a brain damage to the baby. Right now, this is how we complete the resuscitation here. And there are few important things that have to be known. Is how do you count heart rate? Is you just count the pulse for 6 seconds, multiply that by 10. Okay. And then if at all, if you want to give oxygen, now either you can give it through a mask or by your hand, or you can use the mask and the bag. Okay. And these are a few of the complications that can happen at the time of delivery, that the baby might be born with a choanal atresia. That there is, you can see that this particular bone, right? Now this can come down here. You can see that these two bones are joined. So the air cannot enter here, and neither the air can enter like this. So what you need is, you need an oral airway so that the baby can be brought. This is called as a Pierre-Robin syndrome. You can see normally the jaw is like this, it should be placed. But you look at this baby, the jaw is pushed behind so that it closes the air entry, and even this baby needs an intubation. Okay. Now, these are a few of the things that are important to be understood. So if at all, if you get a question on how do you, elaborate or write about newborn resuscitation in detail, we first tell about the risk factors, how much amount of babies require what amount of resuscitation. And then secondly, we elaborately go on defining T, A, B, C, and D of resuscitation, and steps of that. And after that, you can write the entire flow chart, which can elaborately tell. Now, this flow chart I just told you for the knowledge purpose, but you can always download the latest newborn, we call it as NRP, newborn resuscitation program. You can download the latest one, and you can write that flow chart, which is up to date, on today's date, whatever is acceptable. And based on that chart, you can mention about equipments that are used in newborn resuscitation. And once you touch all of them, even if it is a question of, I don't know, Rajiv Gandhi University has 20 mark questions, madam. The major questions, big questions.
10 marks.
10 marks, sir.
10 marks. So this can suffice you for 10 marks. And that's how, and if at all, if you get it for short essay answers, don't write so much, because about everything, you don't write everything in detail. You need to know how much I am supposed to concise, because otherwise it will consume a lot of time. And this is how we attend the answers. Sarita madam, did I attend to everything that was expected?
Yes, sir. Definitely, sir.
Okay. Is there anything that you want me to talk on?
Sir, I want a demonstration on simulator, sir.
Okay. Do we have still time?
Yes, sir. You can, sir. You can, sir.
Yeah. Just a moment. What I'll do is, I will share few videos right now, which shows the resuscitation procedure.
Okay, sir.
Yes. Just give me 1 minute. I'm taking it out.
Okay, sir.
Is the screen seen?
Not.
No.
Screen दिख नहीं रहा है ना? Screen is not being seen.
आपका दिख रहा है बस.
Okay, just a moment. Okay. Just let me know if the voice is audible.
Yes.
What I am showing you, no, it will get clear. Just a moment. There is a demonstration in this. That is the reason why there is a disturbance. You'll experience it. What you will have to do is what I am showing right now is preparation for birth. Right before the person attends to delivery, what all the preparation is going to be done. Is the sound clear now?
Not.
It's not clear.
It's not clear.
It's having literal disturbance, sir.
Okay, just a minute. My fine.
शिशु के जन्म के बाद कभी भी उसे रिसस्सिटेशन की जरूरत पड़ सकती है और रिसस्सिटेशन के लिए मुझे एक हेल्पर की जरूरत है। तो सबसे पहले मैं हेल्पर का चुनाव करता हूँ। प्रदीप जी इधर आइए। आपकी मदद है। देखो अभी यहाँ एक शिशु का जन्म हो रहा है और अगर उसे रिसस्सिटेशन की जरूरत थी तो मुझे आपकी मदद चाहिए। तो आपको शिशु की हेल्प की आपके पास सही है? तो मैं आपको जब कहूँ
Request all the participants to mute yourself. Sir, it's not clear. Still, it is not
Not clear. It's
No,
not clear.
No, sir.
Sir, it is not clear at all.
Okay. Now, what I'll do is I'll mute the voice and then I'll show it. I will talk myself. My voice is clear?
Yes, sir.
Yeah, it's very much.
Okay. Fine. Now, what we are seeing in this picture is the doctor is actually preparing for the delivery and now he has called for a helper and he is asking the helper if he has the ambulance number, whether he knows to count the heart rate and whether he can call the senior doctor if the need arises. Okay. Now, we'll just watch this further. Okay. Now, what doctor is doing is preparing himself for the resuscitation where he's washing hands by using all the 6 steps. After that, the doctor has to wear gloves. Now, once the doctor has worn the gloves, he has to make sure that he has all the equipments that are required for resuscitation. So now the first thing that is required is 2 cloths that are required, and he is taking both the cloths which are placed one over the other. And as per this demonstration, it is that being placed on the mother's abdomen because that is where we have to deliver the baby. This is the shoulder roll which has to be kept aside as per the requirement. Now this is a suction machine. This is called as a Daily mucus sucker, which can be operated by the doctor himself. Now this is the ambu bag which is required for resuscitation, and 2 masks are kept ready, just like that should be appropriate to the size of the nose and mouth of the baby. That is the reason why two masks are taken ready. Both the masks are kept ready. This is the cap that the baby requires after delivery so that the baby's temperature is continued to monitor. Oxygen is kept ready, which need to be connected to the umbu bag as per the requirement. Okay. Now, doctor has to check whether this umbu bag is working or not. So what is done is you hold the mask like that, as being shown. It is fixed on the umbu bag, and then with one hand you hold the umbu bag. You fix the oxygen reservoir. Oxygen tubing is taken and that is fixed at the other outlet. There are two outlets for an umbu bag, as you see there. So an oxygen reservoir, and that is called as a corrugated tube, what you're saying. Now you have to check whether the umbu bag is working. When you squeeze the umbu bag like that, you will feel the pressure on the hand. So if the pressure is felt, that tells you that the umbu bag is working. And then there is a valve here. The valve produces an hissing sound at the time when you want to, when you are checking the umbu bag that it's working or not. So when you feel the pressure and when you find the wall which is being popped up, you can see the wall popped up. Okay, that shows that the umbu bag is fine, working fine. Now the doctor is ready with all the equipments. He is ready with his helper. He is also ready with his equipments and instruments that are required. Okay. Now let us go into the next the video where I'll be showing you fine. The screen is being seen. Screen is seen.
Yes, sir.
Yeah, okay. Now here we are going to see on how a routine care is done. See, the doctor is asking all the questions here. Let's assume that he is asking whether this baby is normal or not. Okay. For this scenario, he asks two questions. Let's assume the baby is delivered, and when the baby is delivered, you announce, say that the baby is breathing and crying, and you announce loudly the time of delivery. Okay, and now the baby is kept between delivered on the mother's abdomen. You wipe the head of the baby, you wipe the trunk and limbs of the baby. The cloth is wet, you remove that cloth. Okay, now the baby is there on the mother's abdomen. Now you again cross check whether the baby is breathing or not. Okay, and this particular is baby is breathing both the side, the lung is ventilated normally and properly. Color of the baby is pink. Okay, then what you do is you take a gauze piece, you dip it in a normal saline, and you wipe the baby's eyes from the medial canthus to the lateral. You use swabs for wiping this, doing this procedure. All right, and then you now know you can cut the cord. Cord is cut, clamp is applied, and then you put a name tag, especially in the areas where multiple deliveries happen. There are chances of misplacing. So this is one of the routine practice that is done. Then cap is put on the baby's head just to protect baby from hypothermia. And you put this baby between the breast of the mother. Okay. With one cloth, you cover the baby. right? And with the other cloth, you cover both mother and the baby and tell the mother to breastfeed the baby as early as possible as the baby has had a normal transition. Okay. Now this care is what is called as a routine care. 90% of the babies need nothing other than what you saw just now. You just need to do what is shown. All right. Now I'll just show you on how initial steps are required. Okay. Now as we took the second scenario where the baby did not breathe immediately after the birth, and what we do here is when the baby does not breathe immediately after birth, what we do is again the same procedures are followed. Baby is delivered on the mother's abdomen, and now this is the second scenario where the baby is not breathing. What you do is you immediately do the initial procedure, do the suction. Baby is not breathing, so first you dry the baby. Okay. Baby is still not breathing. Now you immediately cut the baby, separate it from the mother's cord. You take the baby under the radiant warmer. Once you take the baby under the radiant warmer, you position the baby. You position, see, in that way you position you keep by keeping the shoulder roll. Then you do a suctioning. After positioning, you do a suctioning. Then this is how you give the tactile stimulation. What you saw now is the tactile stimulation. You stimulated, now you reposition the baby. After doing this procedure, this baby is now breathing. Let's assume that the baby is now breathing. Baby's tone is improved. Now, once the baby is stable, you just do the remaining routine procedures that are required. You wipe the eyes of the baby from medial canthus to the lateral canthus in the same way. You clean it from end to end. You use 2 separate swabs for cleaning. Now the cord is already cut, so only thing you have to do is you have to put a name tag to the baby, and then you put the cap of the baby. Okay. After doing this procedure, what you do is you take the baby, keep it between the breasts of the mother. But here you explain to the mother, right? Of course, you need to cover the baby with one cloth. And after you cover, you need to wrap the baby and the mother both with the next cloth. But then here you talk to the mother, you explain to the mother, saying that this baby did not cry immediately after birth, but the baby is now stable, but this baby requires monitoring. So I'll be coming and seeing the baby very often. Right? So you explain it to the mother and then you move. So this is the second scenario that we have. I'll just take you to third scenario, which is the brief ventilation. I'll just showing you this in short. We will not go to the fourth scenario, but this scenario will give you an idea about how exactly the babies are managed. Okay. Now this is the third scenario where baby has not breathed even after doing initial steps. That is, you tried, you positioned, you stimulated, the baby did not breathe in spite of that. Now in this scenario, you need to use a Rambo bag. This is called bag and mask ventilation, where you already checked it and kept it ready. You take the mask in the right hand, you encircle it, okay, do the suctioning, the baby is already in position, do the suctioning, check the position of the baby. Take the mask, you keep the mask in such a way that you first keep it on the chin and then wave it over mouth and nose. Then after that, you start giving breathing by saying breathe 2, 3, breathe 2, 3. Now when you say breathe, you squeeze. When you say 2, 3, you release. So So breathe 2, 3, breathe 2, 3, you go on saying. But there are a few problems that can happen that there may not be effective ventilation. So what you do is you first positioned again, try to see the position was fine. Again, you started saying breathe 2, 3, breathe 2, 3. And effective ventilation has got good lung ventilation. Let's assume the second problem might have happened that there might be secretions. So you suck out the oral cavity and the nasal cavity. You open the mouth wide open and then again re-attempt giving breaths. Again say breathe 2, 3, breathe 2, 3, breathe 2, 3. Let's assume that lungs are still not expanding. What you need to do, a third correction, is you need to increase pressure. You might not be giving enough pressure. So here you start saying breathe 2, 3, breathe 2, 3, breathe 2, 3. Okay. Now here you can see that the baby's lungs are now being ventilated. Can you see there is a raise in the chest of now? And now here he continues by saying breathe 2, 3, breathe 2, 3, breathe 2, 3. Okay, breathe 2, 3, breathe 2, 3, breathe 2, 3, he says. And this ventilation is continued for 30 seconds. And after this, we need to check whether the baby is breathing on its own. If the baby is breathing on its own, we need to slowly taper it by saying breathe 2, 3, 4, breathe 2, 3, 5, breathe 2, 3, 6. And you slowly wait and watch if the baby is breathing. And if the baby is breathing, you withdraw the let's assume this baby has come out after giving positive pressure ventilation. Okay, so now the baby is doing well. Now, but this baby does not go to the mother. You know, this baby needs to go under post resuscitation care, which is given in NICU, so that you can observe the baby effectively, confirm it, and then you send the baby to the mother. Right? Yes. So, was that clear? Was that okay?
Sir. Yes, sir.
So this is about the newborn resuscitation. Okay. I hope I was able to give you a brief idea and a demonstration about how newborn resuscitation is done, what all the care that you do, and how all you go ahead ventilating the baby's lungs in the labor room. Okay. With this small presentation, hoping that it was useful, I thank Dr. Sarita and team who is doing a commendable job in taking Ayurveda all across the nation. Thank you so much, madam, for giving this opportunity. Thanks a lot.
Thank you, sir, for your breathtaking presentation. Hope all delegates are got grip on subject of neonatal resuscitation. Thank you, sir. Sir, I'll claim host back, sir.
Madam?
Can I take the host back, sir?
Yeah, please. Thank you so much.
Thank you, sir. Thank you so much, sir.
Yeah.
Hey, there is nothing.
यार
Prakash sir.
Hello.
Sir, is it audible, sir?
Yes, madam, it is audible.
Sir, 5 minutes, sir.
Okay.
Good afternoon, everyone.
Madam, should I video?
Yes, sir. It's on,
Video.
sir.
Okay.
You are visible, sir. You are visible.
Okay, madam. Okay.
Please share your screen, sir.
Okay.
Good afternoon, everybody. The second speaker of today's session is Dr. Prakash Bisanalli, sir. The topic on which sir is explaining assessment of gestational age. Dr. Prakash Bisanalli sir has completed PG from SDM Hassan. Sir is presently working as Professor and HOD, Department of Komarabhita, Government Ayurvedic Medical, Mysore. So now I request Dr. Prakash sir to start the session.
Hello.
Hello sir. Sir, you are audible. You can start, sir.
Okay.
Okay.
Okay, madam. I will start now the session.
Okay, sir.
Can I start the session, madam?
Yes, sir. You can start, sir.
Okay, madam. First of all, good afternoon to everyone. Om Sri Dhanvantari Namaha. Om Sri Gurubhyo Namaha. Respected teachers, faculty members, and my dear students. So I welcome you all for this afternoon session regarding this exam-oriented syllabus of Kamarbhutya from the Department of Ayurvedic Mahavidyalaya Hubli, Kamarbhutya Department. First of all, I congratulate them because they are organizing such a huge this platform, giving the students regarding topic allotted for me is the gestational age assessment. So first of all, introduction. Regarding the gestational age definition is the estimated age of a fetus expressed in weeks calculated from the first day of the last menstrual period. So all through the 9 months, whatever the fetus is there in the uterus. So regarding the gestational age, so that will comes under all through the pregnancy. So based on the gestational age and after that the birth, so regarding the preterm, the definition goes like this, that is the less than 37 weeks of gestation. So the baby born who has less than the 37 weeks. So those are termed as the preterm babies, and the term babies are those who are more than 39 to are in between the born in between the 39 to 41 weeks of gestation. So those are termed as term babies, and the post-term babies are those who are born more than the 42 weeks of gestation. So gestational age assessment can be done in 3 methods regarding the menstruation history. So, but as the India, so most of the deliveries takes place in the remote areas or in villages where they don't know the exact menstruation date when they have got the last menstruation. In such kind of, but only this is helpful only in case of those nows who regarding the menstruation date. And the prenatal ultrasonography through first trimester, second trimester, and third trimester through the ultrasonography, we can easily with the diagnostic aids define or diagnose in which gestation that fetus is there. And the third one is the postnatal maturational examination. Through the examination observation, we can diagnose or we can name it as the in which gestation it falls, the baby falls. So next, the next regarding this is can be in 4 phases assessment, but the third one is the gestational age assessment I'm going to do. So next, there will be the rapid assessment of gestational age. This is only for the rapid because in newborn babies, so rapid assessment is necessary because of as Dr. Aziz sir told regarding, because soon after the birth there is a time is very precious. So but here regarding as soon as the baby comes out, regarding the scalp hairs, we can see who are preterm babies, so they are fuzzy and woolly, and who are term babies, they are somewhat pigmented, and the post-term babies, those will be silky and properly pigmented hairs are there. And in case of earlobes, so though cartilages are soft and there will be the shape will not be in proper because of as they are preterm babies. And in case of 37 to 38 weeks who are term babies, there will be the moderately or slightly curved the cartilages are there, and it can retain its normal position or recoiling will be there. And in case of the babies who are post-term, who have 39 weeks and more than that gestation, so there will be the properly shape of the cartilages and the pinna, and also recoiling is instant, and the thick cartilages will be there, and also ear will be stiff. And the next criteria is the breast nodule or the breast bud. So in case of preterm babies, the breast bud will be of 2 mm, and in case of 37 to 38 weeks, the breast bud of diameter will be 4 mm, and the post-term babies are the full-term babies who are having 5 to or more than 7 to 10 mm diameter will be there. And in case of the next criteria is the genitalia. Males and females separately we have to, there are criteria are there again. So in case of preterm baby, the testes are not descended and the scrotum will be few rugosities or what you call the folds, and hypopigmented will be there. And also in case of term babies, good rugosities, and also the testes will be descended. And in case of full term baby or more than 39 weeks of gestation, so those testes will be properly descended, and the scrotal sac or the testis will be pendulous, deep rugosities will be there. And in case of the creases, sole creases, so in the preterm babies, only the anterior creases will be not superficial, and in case of the term babies, the anterior 2/3 sole creases will be there, and in case of full term babies, there will be the entire sole is having the creases. So regarding the gestational age assessment, so that is new Ballard score system is the method where the we can assess the baby regarding the those criteria mentioned in the Ballard score. So the Dr. Jane L. Ballard in 1991 he was proposed this Ballard score, and there are 6 external criteria are there. Physical, those are physical criteria, 6 in numbers, and also the neuromuscular criteria. Again, there are also 6. So depending upon these physical and the neuromuscular assessment criteria are the points are the criteria. So one we can diagnose the baby in which gestational period it falls. So again here the from 20 weeks of gestation to 44 weeks of gestations, we can diagnose or we can name the baby in which particular gestation period it falls. So scores range from -10 to plus 50. So the babies who are less than 10 scores having the maturity will be, or the maturity will be of 20 weeks of gestation, and the babies who are having scored plus 50, so they are having the 44 weeks of gestation. So the optimal time for assessment is from birth to 90 hours. So because soon after the birth, one has to do the assessment of the gestation. So these are the neuromuscular maturity criteria, or the points, or the factors where there will be the regarding the posture. So the first one is the posture. So whether it is a flexion posture or semi-flexion or the extended posture, so we have to assess by the observation, which is on the supine position, and also there are square window test, or the which is observed in case of wrist, and also in case of the arm recoil. So arm recoil, it is also examined in the over the supine position, and the popliteal angle in case of lower limbs to differentiate between the preterm and the postterm babies. So again in case of the scarf sign. So scarf sign, again this is also in case of the upper limbs, we have to follow this scarf sign. We have to see or observe the scarf sign in case of preterm babies and the term babies. The scarf sign is also helpful for the diagnosing, and also in case of heel to ear. So here in case of heel to ear this maneuver, so the examiner, the passive, we have to do this maneuvers, okay, and then there is a new Ballard scoring, the physical maturity criteria. So here there will be the physical, there are 6 criteria are there regarding the physical. The first one is the skin. So here in the skin, we have to observe for the superficial veins, and also there will be the color and the texture. So whether the subcutaneous fat is present or absent, regarding all those skin, we have to observe, or we have to palpate smoothly. And also there will be the lanigo. So lanigos are whether the body hairs which are downy, that is whether they are soft or abundant or they are thin. So regarding that also we have to observe for here in case of laryngos, there is the second criteria. And the third criteria is the plantar surface. So where there will be the creases. So the creases, plantar surface, whether the creases are whether present entire sole, or they are restricted to only the anterior surface, or they are the less in between the heel to toe 40 to 50 millimeter. If they are present, so then it will be -1 grading will be there, or if it is less than 40 mm, then it will be graded as -2 score. So like that, if they are anterior 2/3 of the sole is there, then it will be graded as 2. So like that, we have to grade the regarding the palmar creases or the sole creases, and also there will be the breast bud. Okay, so in case of breast bud, grading is given if it is imperceptible, so that is will be graded as -1, and if it is perceptible or barely perceptible, it will be graded as 0. And also if it is flat areola and no bud, so it will be graded as 1. And if it is stippled areola and 1 to 2 bud is there, then it will be graded as 1. And raised areola 3 to 4 bud is there, then it will be graded as 2. And full areola and 5 to 10 bud is there, then it will be graded as 4. So like that, like this, we have to grade regarding the new polar score about which is observing the criteria regarding the breast bud. So then now next coming to the criteria, that is eye or ear. So in case of eyes, the lids, whether they are open closely, tightly or loosely. If they are closed loosely, it will be graded as 1, and if they are closed tightly, it will be graded as 2. And so then there will be the so and, so then there will be the pinna will be slightly curved and soft, slow recoil, then it will be graded as soft but ready recoil, then it will be graded as 2. And well formed and instant recoil is there, then it will be graded as 2. And if it is the thick cartilage and ear is stiff, then it will be graded as 4. So regarding this is eye or ear examination, the pinna where the shape and the recoiling of the pinna is observed and graded. And also in case of the genitals, male. So the male baby having the scrotum, so scrotum flat and smooth, it will be graded as -1. And if the scrotum empty and faint rugae are not properly clearly visible, then it will be graded as 0. And if testis in upper canal and rare rugae, okay, so because the testis, they are earlier in the abdominal cavity, they have to descend. So if they are in upper canal and they have to, so then it will be graded as 1. And testis descending, few rugaes are there, then it will be graded as 1. And also there will be the, so in case of the third grading, so testis down and a good rugae folds and properly pigmentation will be there, then it will be graded as 3. And if they are testis are pendulous and deep rugae and properly pigmented, then it will be graded as 4. So same in case of the female baby regarding the external genitalia. So to diagnose whether or to make it to name it as a preterm or the term or the post term. So there will be the clitoris will be prominent, and there will be the labia will be flat. Okay, that will be, if it is their condition, then you have to grade it as -1, and we have to grade it as a 0 if there is again prominent clitoris and also the thin or labia minora small is there. And if you have to grade it as 1, if there is a prominent clitoris and enlarging minora is there, then you have to grade it as 1. And in case of grade 2, so the labia majora and minora are equally prominent. And in case of, so there will be the grade 3. So labia majora and minora majora will be large and the minora will be small. And in case of 4, the grading regarding the majora covers the minora and also the clitoris. So these are the what you call the criteria regarding the physical maturity criteria are there. So then now we will see the neuromuscular maturity regarding the posture. So the posture or the position in the supine position. So we will see what are in the neuromuscular maturity, what are the points or the criteria are there. The first one is the posture, and the second one is the square window test, which is observed in case of the wrist joint, and the arm recoil in case of the both the upper limbs, and the popliteal angle in case of the lower limbs, and the scarp sign again in case of the upper limb we have to see, observe, and heel to ear maneuver. So that is, so these are the 6 criteria are the points we have to for the neuromuscular assessment, or these are the criteria are there. So the first one is the posture. So posture, as by observation, if it is in the over the supine position, we have to see the flexion of the all the joints. The term baby will be in a flexed position, because all through the 9 months in the womb, it will be in a flexed position, anterior and flexed position. The same, if the term baby is there, the same posture will be maintained in the extrauterine life also. But if it is a preterm, due to the laxity, all the 4 limbs will be in a extended position. So the score is assigned based on the degree of flexion. That is nothing but the tone or the arms and knees and hips are, if they are more in flexor condition, so it will be grade will be given good grading. And increased flexion and hip adduction increases as the gestational age increases. So this picture will give you the clear-cut idea. So regarding the, see the both the upper limbs and the lower limbs are in a flexion posture. Okay, so this is the, so grading 0 will be given if there is a extended, both the upper and lower limbs are there, somewhat extended in case of grade 1, and in case of grade 4. See, you can see the all the 4 limbs in a well flexed position are there, both the upper limbs and the lower limbs. It will be graded as a 4. So next one is the square window test. It is performed in case of the wrist joint with the examiner. So he can with his dominant hand, so he can flex the both the wrist joint, that palm or the thinner aspect of the palm, whether it is touches the forearm. So if it is touches the forearm, then it will be in case of turn baby, and if it is, there will be the square window type of shape will be there, then it will be in case of preterm babies, because the joints and the cartilages are not well formed. So this picture will give you the correct idea. This is the square window test where the hypothenar the palm is not properly attaches or touches the forearm portion. So okay, so these are the gradings will be given. So next one is the arm recoil. So this maneuver focuses on the passive flexor tone of the biceps muscle by measuring the angle of the recoil following very brief extension of the upper extremity. So here the examiner, we have to, the examiner has to flex both the upper limbs for 5 seconds and then suddenly extend and release suddenly, so that when if the, then we have to observe whether the flexion is the brisk, if it is the turn baby is there, then there will be the brisk flexion will be there, or if it is the hypotonic, or if it is a preterm, so then there will be the sluggish flexion movement will be there. So this is the arm recoil. Okay. So next one is the popliteal angle. Again, it is also the maneuver performed over the supine position, somewhat hard matrices. So where there will be the examiner is pushing the thigh region to the adjacent to the chest and the abdominal portion, and then with the other hand or the other thumb and index finger, so you'll extend the lower leg. So if there is a, we have to stop when there is a resistance, and we have to measure the angle, so that will give you the popliteal angle. Where here also the term babies, they will give some resistance, but in case of preterm babies, so there will be the more angle will be formed. And next one is the scarp sign. The scarp sign, again here there will be the the baby is in the supine position, the head should be in the midline position. The examiner has to hold the one hand of the baby and has to pull across the neck towards the other side. If the midline of the elbow joint, if it crosses the midline, the imaginary midline of the body, so then it will be a preterm baby because of a proper tonicity is not formed. So if it does not crosses the midline of the body, so then the proper tonicity has been formed, so that we have to term it as the term baby. Okay, so this picture will give you the proper idea. So here there will be the, with one hand he is pulling the baby's arm to across the one side crossing the midline. So here in this picture, the elbow joint is properly exactly at the midline of the body. So it will be graded as a 2. So this is the scarf sign one has to do. Okay, next regarding the heel to ear test. So heel to ear test, where there will be the, so the examiner has to again flex the that is the thigh region or adjacent to the or attached to the neck and the abdomen and the chest, and then with the other hand so with the further extending the lower leg, he has to draw as near to head as possible. So here we have to note the distance, observe and the distance between the foot and the head, as well as degree of knees of extension. In case of preterm babies, so there will be the easy movement of the lower leg will be there up to ear, but in case of term babies, so there will be the resistance will be there. So depending upon that one, we have to grade it as a, whether it falls in the grade 1, 2 or 3. So like this, so these are the the neuromuscular maturity criteria. So again, the skin, lanigo and plantar surface, breast, eye, ear, and genitalia. So these are the physical maturity criteria, as I have already told. Okay, so regarding this, the lanigos, whether they are sparse lanigos, and if they are, so the lanigos we have to see in the upper back and over the shoulder, whether they are abundant or the sparse or the, so like this here, they are, we have to grade it as -1 if there is no lanigos are there. If they are sparse, we have to grade it as 0. And if they are abundant, we have to grade it as 1. And if there is thinning of the lanigo is there, then we have to grade it as 2. And if there are some bud areas are there, we have to grade it as a 3, and most badly, then bud areas if you found, then you have to grade it as 4. So again, there will be the plantar surface. So here plantar surfaces, we have to see the creases. So there will be the, as already told, if there are creases are over anterior 2/3 of the sole is there, then we have to grade it as a 2. So like, and if there are creases all over the entire sole is there, then we have to grade it as 4. So the breast bud, the areola is raised by 34 weeks. By 37 to 40 weeks, the nodule is more than or up to 10 mm. So here, -1, the if perceptible, or in 0, barely perceptible. If it is degree 1, there where there will be the flat areola will be there and no bud, and we have to palpate with the index finger, and we should not stretch the chest portion, because and there will be the disturbance will be there to measure the diameter. And eye or the ear, so eye in case of the closed lid are there, it will be, so if the lids are closed or fused loosely, then it will be graded as -1. If they are tightly fused or closed, then we have to grade it as -2. And the lids open, pinna flat and stays folded, then we have to grade it as 0. Like that, in case of grade 4, thick cartilage will be there and ear will be tough. So the stiff ear will be there, and the proper formation of the cartilages or the pinna of the cartilage will be there. So like that's genitalia, as I have already told. So regarding the maturation of the gestational assessment, the maturity, like this, we have to grade the babies regarding the assessment of the gestational maturity by these 6 physical characters and the 6 neuromuscular characters regarding the which is told by Jean L. Ballard in 1991. So he proposed this new Ballard score. Along with this, there are other scores are there to assess. Okay, so with this, I thank you one and all for bearing me. Okay, if there, so I think there are so many mistakes. So okay, thank you, madam. Can I? Hello, hello.
Hello, sir. Hello, sir.
Madam. Can I finish?
Yes, sir. You can. You can end, sir. You can end the session.
Okay, madam.
Thank you, sir. Thank you very much for wonderful talk.
Okay, madam. Thank you. Thank you.
Thank you, sir. So now I request. Hello. Now I request speakers. Hello.
Hello.
Hello,
Hello, madam.
Sir, you
Hello,
can
madam.
end the session, sir.
Okay,
You can
madam.
end the session, sir.
Stop sharing. Stop sharing. New sharing.
Okay, madam. Thank you.
Speakers again.
Now I request to all the participants, if they want to share anything or they have the suggestions or the questions, they can share. Dr. Sharda Madam, Dr. Shain Sir, Dr. Vijayalakshmi Madam, Dr. Reena Madam, Dr. Purushottam Sir and Aziz Sir. If they want to share anything, they can share. Otherwise, other participants, if they have the questions, they can put forth.
Hello, Sarita Madam.
Yes, Madam.
The presentations were really good. I just want to comment so much. It was very educative.
Thank you, Madam.
Thank you, ma'am.
Other participants?
If any participants is having any queries, then they are most
to ask.
welcome and free to ask.
I think there are no questions or any suggestions to the today's session. So we can end now, Madam, Sir. Okay, we are going to end the today's meeting. Thank you for being throughout the session. Thank you and all.